Diabetic foot ulcer, or DFU, is a serious and costly complication of diabetes, often leading to lower limb amputations worldwide. Today, we'll cover everything about DFUs, from definition, signs, diagnosis, and investigations, to comprehensive management and prevention. A DFU is a full-thickness skin break below the ankle in a diabetic patient, typically caused by neuropathy, ischemia, or infection. It signifies the body's failure to heal due to a complex interplay of vascular, neurological, immunological, and mechanical factors. Globally, over 25% of people with diabetes will develop a foot ulcer, and tragically, every 20 seconds, someone loses a limb due to diabetes. Up to 85% of diabetic amputations begin with a foot ulcer, and recurrence rates are alarmingly high, reaching 65% within 5 years. Signs and symptoms vary based on the underlying cause. Neuropathic ulcers often present as painless wounds on pressure points, with warm, dry feet and loss of protective sensation. Ischemic ulcers, however, are characterized by cool or pale feet, pain at rest or with walking, weak pulses, and typically appear on toes, margins, or the heel. Infected ulcers show increased pain, warmth, purulent discharge, bad odor, surrounding cellulitis, and systemic signs like fever or chills. Diagnosis is clinical. Any skin break below the ankle in a diabetic patient should be considered a DFU until proven otherwise. A holistic assessment includes neurological and vascular examinations, wound classification systems like Wagner or Sinbad, and evaluating depth, size, location, and signs of infection. Investigations guide management, starting with neuropathy tests like the 10-gram monofilament, vibration with a 128 Hz tuning fork, and pinprick sensation. Vascular tests include ABI, TBI, Doppler waveform analysis, toe pressures, and transcutaneous oxygen measurements, with duplex ultrasound or CT angiography for revascularization planning. Infection workup involves deep tissue culture, X-rays for bone involvement, MRI for osteomyelitis, and blood tests like CBC, ESR, CRP, and procalcitonin. The primary goal of DFU management is to heal the ulcer and prevent amputation, requiring a multidisciplinary approach. Key pillars include treating the underlying cause, offloading, debridement, infection control, moist wound care, and revascularization if needed. Other crucial aspects are glycemic control, proper footwear, and patient education. Offloading is vital for neuropathic ulcers. Without removing pressure, the wound will not heal. Options range from total contact casts, which are the gold standard, to removable cast walkers, half shoes, insoles, and even wheelchairs for severe cases. Dressings maintain a moist wound environment, manage exudate, control bioburden, and protect the wound. Common categories include foam, hydrocolloids, alginates, hydrogels, silver, honey, and negative pressure wound therapy, chosen based on wound status using frameworks like timers. Surgical interventions include debridement, drainage, deformity correction, revascularization, and, if necessary, amputation, all aimed at limb salvage. Proper diabetic footwear, featuring a wide toe box, soft lining, and rocker sole, is crucial for pressure redistribution and can reduce recurrence by 50%. Prevention is key. Regular foot inspection, glycemic control, podiatry care, offloading, and avoiding walking barefoot are essential. Smoking cessation, patient education, and early referral to specialists further reduce risks.